Hello everyone, welcome back to Learn Anesthesia Basics. Today we will be discussing about physiological changes in pregnancy. In this topic we will be discussing about all the physiological changes that happen in pregnancy and why do these changes happen. The physiological changes in pregnancy are due to the changes in maternal anatomy and physiology, secondary to hormonal activity, mechanical effects of enlarged uterus, increased maternal demands, and biochemical alterations by fetoplacental unit. Which let's see these changes from from CNS, then RS, then CVS, like that we will go. The first physiological changes, let's check out CNS, central nervous system. Central nervous system, the pregnant mothers are more sensitive to inhalational and local anesthetics. There is a decreased requirement of almost 40% of the local anesthetics in pregnant women. And there is also decrease in the MAC. MAC will be decreased by 28% in first trimester. And this decrease in the MAC can be multifactorial. And one of the causes of decrease in the MAC is progesterone released from the gravid uterus. Next, in term pregnant women, the epidural veins are distended. Epidural fat, the volume of epidural fat is increased and the size of epidural space is decreased. So the volume of CSF is also decreased. The CSF pressure is increased. This causes increased spread of local anesthetics. So in central nervous system, there is the decreased requirement of local anesthetics to the patient and a more rapid spread of local anesthetics in the patient. When coming to the respiratory system, airway, there will be capillary engorgement, tissue friability, edema of mucosal lining of oropharynx and larynx. This causes increased risk of bleeding to the patient and increased difficulty in mask ventilation and intubation. So, what are all the precautions we have to take while dealing with a pregnant woman? Should do gentle suctioning and while placement of devices, avoid nasal instrumentation, decrease the number of attempts of intubation, use of smaller ET tubes, and to make sure there is an availability of video laryngoscope in the operation theatre. When it comes to ventilation and oxygenation, the tidal volume increases by 40 to 45% and respiratory rate increases by 0 to 15%. Tidal volume into respiratory rate is minute ventilation, which increases by 45 to 50%. The maternal oxygen dissociation curve shifts to right. PaCO2 decreases from 40 in non-pregnant women to 30 in pregnant women, and during labor it decreases to less than 20. PaO2 is 100 in non-pregnant women and it slightly increases to 103. Bicarbonate from 24 it decreases to 20, and pH from 7.4 in non-pregnant women it increases to 7.44. This is mildly alkalotic. P50 increases from 27 to 30. There are only two components which decreases, that is PaCO2 and bicarbonate, which decrease, and all the other factors increase in a pregnant woman. Oxygen consumption at term increases by 20 to 35%. In first stage of labor, it increases by 40%, and during second stage of labor, it increases by 75%. When coming to lung volumes, as we have already discussed, the tidal volume increases by 20% in first trimester and increases by 45% by term. Functional residual capacity decreases by 20%. This is due to cephalad displacement of diaphragm. Expiratory reserve volume decreases by 20 to 25%. Residual volume decreases by 15 to 20%. The closing capacity is unchanged. FRC by CC ratio decreases. Vital capacity no change. Inspiratory reserve volume increases by 0 to 5%. Inspiratory capacity increases by 5 to 15%, and total lung capacity decreases by 0 to 5%. So because of increased minute ventilation and decreased functional residual capacity, there will be rapid rate of alveolar concentration of inhalational anesthetic agents. This also explains why there is rapid desaturation and hypoxemia in pregnant patients. This is because of decreased oxygen reserve, that is FRC, and increased oxygen uptake because of increased metabolic rate. When coming to the cardiovascular system, the heart shifts anteriorly and to left. So, left axis deviation and left ventricular hypertrophy are common in pregnancy. When coming to auscultation, first heart sound is accentuated. Second heart sound, there is increased splitting of second heart sound. There will be dissociated closure of tricuspid and mitral valves. S3 can be seen in final trimester and S4 can be heard because of increased volume, that is turbulent flow. There can be a systolic ejection murmur of benign systolic ejection murmur, benign systolic ejection murmur of grade 2 by 6 at the left sternal border, secondary to mitral regurgitation at tricuspid wall from annular dilatation associated with increased cardiac volume. Now we have seen auscultatory changes. Let's see what ECG shows. There will be heart rate dependent decrease in the PR and QT intervals. Small QR axis shift to right in first trimester or left in third trimester. ST depression of 1 millimeter is seen in left precordial and limb leads. Isoelectric T waves are also seen in left precordial and limb leads. Small Q wave and inverted T wave is seen in lead 3. When coming to 2D echo, heart can be seen as anterior and leftward displacement is seen. Right-sided chambers increase in size by 20%. Left-sided chambers increase in size by 10 to 12%. There is left ventricular eccentric hypertrophy seen in normal pregnancy. Ejection fraction increases. Mitral pulmonic tricuspid valve annulus increases. Aortic annulus is not dilated. Tricuspid regurgitation and pulmonary regurgitation are common. Occasionally, mitral regurgitation can be seen, and there will be small, insignificant pericardial effusion. When coming to intravascular volume, there will be an increase in the intravascular volume by about 35 to 45%. This is due to increased progesterone from the gestational sac, which causes changes in the renin-angiotensin-aldosterone system, which causes increased sodium absorption and water retention. This increased intravascular volume of 35 to 45% returns to normal by 6 to 9 weeks postpartum. Out of this intravascular volume, plasma volume increase is 45 to 55%, red cell volume increases 20 to 30%. This causes dilutional anemia in pregnancy. This also causes decrease in the plasma protein concentration. Out of this, albumin concentration decreases by 25% and total protein concentration decreases by 10%. The colloid osmotic pressure changes from 27 millimeters of mercury to 22 millimeters of mercury. The cardiac output increases by 35 to 40% at 35 to 40% at the end of first trimester and increases by 40 to 50% at the end of second trimester. As we already seen, stroke volume increases by 25 to 30%, heart rate increases by 15 to 25%. So cardiac output fluctuates with uterine contraction. So Pre-pregnant values, pregnant values, and labor values are different with respect to cardiac output. In first stage of labor, the cardiac output increases by 10 to 25% above the pre-labor values. And in second stage, this increases by 40% above pre-labor values. Immediately after delivery, this increases by almost 80 to 100%. This is secondary to autotransfusion of uteroplacental blood and decrease in the maternal vascular capacitance from loss of intervillous space, and also due to decrease in the lower extremity venous pressure. This causes autotransfusion and increase in the cardiac output immediately after delivery. This cardiac output returns to pre-labor values by 24 hours postpartum and to pre-pregnant values by 2 weeks to 12 to 24 weeks after delivery. The systemic vascular resistance decreases by 20%. This is due to vasodilator effects of prostaglandins and progesterone and low resistance of uteroplacental vascular blood. This causes decrease in the blood pressure, which is uh, the diastolic blood pressure decreases more than systolic blood pressure. This causes widening of pulse pressure. The pulmonary vascular resistance decreases by 35%. Central venous pressure and pulmonary capillary wedge pressure, there will be no change. This is due to increase in the venous capacitance. Femoral venous pressure increases by 15%. After this, let's come to the important concept of aortocaval compression, which happens in a pregnant woman. When the pregnant woman lies supine, there will be aortocaval compression by the gravid uterus, which causes fall in BP. This is called supine hypotension syndrome or aortocaval compression syndrome. This occurs in 8 to 10% of the pregnant women. In them, MAP decreases by more than 15 mm of mercury and heart rate increases by more than 20 beats per minute. This is associated with nausea, vomiting, changes in mentation, and diaphoresis. What happens at term? At term gestation, when a pregnant lady lies in supine position, there will be complete occlusion of IVC. This restricts the return of blood from lower extremities, and this causes return of blood from lower extremities by epidural, azygous, and vertebral veins, and significant aortoiliac artery compression in 15 to 20% of the women. This causes venous stasis in the legs, causing ankle edema, varices, and increased risk of DVT in the pregnant ladies. And compensatory mechanism or compensatory adaptations in pregnant ladies are there will be reflex increase in the peripheral sympathetic nervous system, which causes increase in the systemic vascular resistance and maintains the BP. So when we give a spinal anesthesia or general anesthesia, the sympathetic nervous system is blocked. This causes exaggerated hypotension in pregnant ladies. This can be avoided by tilting the bed by 15 to 30 degrees. When coming to hematological manifestation, as we have already established, there will be physiological anemia in these patients. So hemoglobin normal will be considered as 11.6 gram per deciliter because of additional intravascular volume of 1000 to 1500 ml. Leukocytosis is seen in these patients. So the normal range of WBC is increased up to 13,000. Coagulation. Pregnancy is hypercoagulable state. So the procoagulant factors like 1, 7, 8, 9, 10, 12 and von Willebrand factor are increased and 11, 13 is decreased. 2 and 5 of procoagulant factors are unchanged. Out of these, the anticoagulant factors are antithrombin 3, protein S and protein C. Protein C is unchanged antithrombin 3 and protein S are decreased. This causes 20% decrease in the PT and APTT. Platelet count can be normal or decreased by 10%. When coming to thromboelastography, thromboelastography is kinetics of clot formation and breakdown. So the start of clot formation, that is R value, is decreased. Specified clot strength K value, the time for specified clot strength K value is also decreased. Rate of clot formation, that is alpha angle, is increased. Clot strength or maximum amplitude is increased. These are the changes which we can observe in a thromboelastography. When coming to GIT, the stomach and pylorus are normally moved cephalad. Along with the stomach and pylorus, the intra-abdominal portion of the esophagus is repositioned intrathoracically. This causes decrease in the lower esophageal sphincter competence. This estrogen and progesterone also acts to reduce the lower esophageal sphincter competence. Gastrin is secreted from placenta, which causes increase in the hydrogen ions and decrease in the pH. With the decrease in lower esophageal sphincter compliance, decrease in the pH, and increased gastric pressure by the gravid uterus, there will be increased risk of acid reflux and regurgitation in the pregnant patients. So, non-particulate antacid and rapid sequence induction with cricoid pressure are performed when we go for general anesthesia in pregnant patients. When coming to hepatic and biliary changes, AST, ALT and bilirubin are increased. ALKP more than doubles because of the secondary production from placenta. Plasma cholinesterase activity decreases by 25 to 30% from 10th week of gestation to 6 weeks postpartum. 10th week of gestation to 6 weeks postpartum. There is increased free levels of protein bound drugs. When coming to gallbladder, there will be incomplete emptying of the gallbladder and changes in the bile composition causing acute cholecystitis in pregnant patients. This is not a physiological change. When coming to renal changes, renal blood flow increases by 60 to 80% mid-pregnancy and more than 50% increase by third trimester. Glomerular filtration rate increases by 50% from third month of gestation to third month of postpartum to 3 months postpartum. So there will be increased clearance of urea, uric acid and creatinine. Serum creatinine and blood urea nitrogen levels decreases by 50%. Urine protein and glucose clearance increases because of decreased renal tubular reabsorption. That's it for today. Thank you for watching. Please like, share and subscribe.